Hi, I'm Sebastian Ryland with Streamline Forensics. So I do a lot of consultation for folks who work in general, like clinical assessment practice. And a lot of them are approached by someone who wants to know if they can take a case. More often it's kind of like a pseudo forensic case. So like maybe evaluating someone who's in a proceeding, but it's not like a classic forensic referral. And so the assumption is often that you can come in and just do your normal clinical assessment gig and they'll take it in court and use it how they need and understand and respect the limits of what you can offer as a clinical practice specialist. That's just not how court works, unfortunately. So the rules of procedure dictate that if one side seeks to offer information through either an expert or a fact witness, and you might be either, depending on the circumstances of your referral, in order for that information to be considered by the court, it needs to be available for scrutiny through the adversarial process. And so that means that both sides need to be able to question you if they want. So I probably don't need to tell you that clinical and forensic practices are different worlds. But I have seen at times, maybe more as the norm even, that I think many clinical specialists can underassume just how different these practices are. So you might be like an amazing general medicine practitioner, but you're not going to jump into heart surgery. Or you might be a world-renowned heart surgeon, but you're not going to just jump into brain surgery. So in most instances, if you have to ask whether this is an appropriate referral for you, then referral to a forensic specialist is probably the answer. But if not, you should expect to pay for consultation and maybe even supervision. So let's say you decide to move forward. You want to give this referral a shot. One of the best pieces of advice that I can give you if you decide to move forward is to clarify roles repeatedly and thoroughly. So you cannot have a treating relationship with this person and then move into an assessment role. There are some loopholes to that too, I can think of off the top. So if you're in like a low saturation area where there isn't another provider who can provide the service and withholding the service can cause harm, historically, that's been a time where we could kind of relax this expectation. Although in the age of video assessments, honestly, I think that case is getting harder to make. But use your judgment. And then another thing that I've seen come up occasionally is like, if it's the kind of service that sort of borders on assessment, but it doesn't really need to be referred out. So like if someone needs a letter stating that their decision to complete plastic surgery was mentally sound. It wasn't like mania or something. They don't need an MMPI. That's an opinion that you can provide as a treatment provider without making them get a $500 pre-surgical evaluation just to show a family court judge that, it was within bounds of their, treatment parameters and expectations or whatever. Like, again, use your judgment. But those are one-offs. I had to work really hard to kind of even come up with those. Most commonly, if you have any treating relationship prior to being asked to do an assessment, the answer is just categorically no. Refer it out. So another suggestion, and this is maybe even like the heart of the message here, do not underestimate how differences in like the expectations and practice sort of guidelines can really change your expectations and your experience. For example, like in clinical assessment, there's a wider range of acceptability for like discussing other people in an evaluation. So like you're evaluating a kid and you think the mother should pursue treatment on her own. And you got to be really careful with that even clinically, right? But that's probably an okay rec to allude to in a clinical evaluation under the auspices of helping the child obtain like optimal stability. But in a forensic evaluation, you can like easily land a board complaint for offering a recommendation about someone that you didn't examine. Even that language around like examining versus interviewing, like those are some different things that you should just know and expect. There are different parts of the process here. So another example of really different expectations is around testing. So most people who do clinical assessment, at least the ones that I know, use testing in almost every evaluation, maybe even every evaluation. There's like leeway for using tests in a way that I would call like off-label. I don't think that's a real way to use that, but the best clinicians can take a subtest of something and use it to explore a hypothesis about something that comes up in testing because they really know the underlying construct for like what that subtest is measuring. And that's amazing. That's an incredible thing to be able to offer in a clinical assessment. But in forensics, there's very little leeway for that because our tools are subject to the rules of evidence and the admissibility standards. Similarly, related to testing, the expectations around using testing at all are really, really different. So, forensics, something like a competency evaluation, for example, testing is the exception and not the norm. I actually rarely use testing in my competency evaluations. I really only use it in very specific ways if I need to answer the forensic question, because the forensic question is highly specific and focused. And so absolutely nothing in our reports should be in there if it's not directly relevant to that forensic question. So I've seen clinical folks look at what I would consider a perfectly adequate competency evaluation and conclude that it's deficient in some way, either because it's too short or it didn't use testing to assess some kind of construct. Instead, it leaned on, like, let's say a special education record that had, where testing had been done prior and they didn't do their own. Those are really normal, acceptable practices in forensic assessment that, are less common clinically, right? But it would be sort of like if I picked up like an ultrasound or I don't know, an x-ray or something. You can tell I'm not a doctor. And I decided like I can read it because I can see that this is a leg, right? But it doesn't mean that I understand like all the nuances of what I'm looking for. I might be able to identify a break, but I might not know like what kind of break, or or I might misdiagnose that break. Or there's all kinds of things that you're vulnerable to when you're not familiar with the terms and expectations and guidelines and boundaries of a particular specialty area. I think that even that reference I made to collateral information, that's even another difference between the two expectations of the two worlds. That's really important. In the clinical world, you're going to rely a lot more on self-report, and you're not going to pursue multiple sources of data and really comb through those collaterals in a way that that's pretty standard practice for us in forensics. And so you can really get into trouble if you don't understand that ratio is flipped on its head, that we're not relying very much on, or maybe we're relying differently on, the examinee's self-report. There's other differences related to that in terms of like who's the client, but mainly those are just like a few examples to give you the flavor of ways that you can get into trouble, like if you don't know what you're looking at and you're sort of crossing into the world of forensics. So the most common comment that I see when somebody's considering crossing into the forensic realm is in like that, maybe that pseudo referral that we talked about earlier, where like a lawyer says, hey, we're in this custody evaluation, but we just need a diagnostic on this kid. So, yes, it's a custody evaluation, but we don't want you to do your normal evaluation. And by and large, this will happen. People will seek consultation, which is a great instinct, right? That's like right on. It's what you should do. But they'll open the consult with a question of like, I want to take this case, how do I stay out of court? And I hate to say that really the answer is that if that's your question, you should refer the case out. And that's not a great answer, or maybe the answer people were hoping for, but that is the answer. That the vast majority of evaluations that are in relation to a legal hearing like do not result in a hearing or testimony, but that is the playing field that you're entering. And so it's possible and maybe even likely in certain cases, especially if like an attorney didn't seek a forensic specialist, there may be a reason why. Even if there isn't a reason that they did that, they just know you, or they had contact with you some other way, or they found you on Google and they thought maybe it was close enough, whatever it is, you saying, I'll take it, but I want to stay out of court is sort of the equivalent of like a psychiatrist if they were to say, yes, I'll take on that new client, but only if we can promise that they'll never have an adverse reaction to any of the medication that I prescribe, right? Like you can't do that. What you can do is charge a higher hourly rate for forensic work than for clinical work. You don't get to set that rate so high that people won't call you into court. And I'd really recommend against having a different fee structure for testimony. I would really recommend that all your time be billed at the same hourly rate. So ultimately, forensic evaluation is like an incredible specialty, but it is a specialty. And so you can't expect to jump into it with like a clinical lens and just hit the ground running. You should expect to pursue paid consultation or even supervision if you don't have any experience. Pay for trainings and CEs, read books and articles. Now there's also like a huge base of case law that you'd need to get familiar with in your specialty area to understand why like certain things are or are not done. So at an absolute minimum, you would need to get and read. And again, this goes for even like your pseudo evaluation where you think you're just doing a general diagnostic. You must understand the playing field that you're working in. So this would generally be like a definition of terms or concepts related to the construct that you're assessing. And then your goal in a forensic assessment is to offer an opinion about whether your examinee does or does not meet some or all of the prongs of that particular construct, and then why. You absolutely must provide a foundation for all of your opinions. The guiding discourse here would be that you should very clearly separate like your data from your inferences. So like outline records earlier in your evaluation before you ever get to discussing them in conclusions. And that's not antithetical to approaches in clinical assessment, but I do think in forensics we're a lot more particular about that. And then only answer the question that you're being asked. You should typically only be assessing somebody in response to a prevailing authority. So you should have a court order. That's most common, or some other, maybe sometimes there's like administrative guidelines around when certain assessments happen. So ultimately, this is just like a toe in the water of some of the differences between clinical and forensic assessment. It's sort of like what I would imagine the difference would be between like speaking French and speaking Spanish. I don't speak either, so hopefully that analogy makes sense. But like, even if the origins of those languages are related, and maybe even some words are shared, they're different languages. They're fundamentally different languages. And so if you're considering learning French and you speak Spanish, you probably don't want to just drop into Paris without any preparation for some of the culture shock that you may rightfully experience. So read, train, consult, tread carefully, and move slowly. Good luck. This is Sebastian Ryland with Streamline Forensics.